afternoon, everyone. Welcome to the Underserved Population Network webinar. This is Misty Kevich from HHQI. Also with us from our team is Andrea Lefke and Misty Dyke. So we want to thank you for taking your time out of your day today for a very interesting topic. I think you'll all be find very fulfilling and interesting. We are pleased today to have Jane Marks as our speaker. Jane has worked in the nonprofit arena for 24 years and includes the role of Executive Director of the Alzheimer Association in the West Virginia chapter. She now spends her time speaking, training, and managing her website, www.sandwichcaring.com, which you'll hear more about, and it's dedicated to those people who are sandwiched between their own lives and the task of caring for aging parents. Her time with the Alzheimer Association, Jane has developed a broad knowledge and a keen awareness of the impact Alzheimer's or other related dementias has on families. Jane is acknowledged by healthcare professionals as a subject matter expert capable of transforming a complicated set of circumstances into patient-centered solutions. Jane is the author of numerous articles and has developed and presented a wide variety of training programs and curriculums on all facets of Alzheimer's disease. She served on numerous work groups, task force, both regionally and nationally surrounding aging issues. Jane has presented workshops throughout West Virginia and at the National Alzheimer's Association Leadership Conferences and Public Policy Forum, as well as at the White House Conference on Aging Solutions Forum. She has served on the Strategic Planning Steering Committee for the National Alzheimer Association, as well as the National Strategic Alignment Work Group. Jane is published author of multiple journals and articles on aging and Alzheimer's, as well as motivational book on divorce survival for women. For over the last 4 years, Jane has hosted a monthly talk show on the local cable net channel titled Women's Perspective, which often focuses on aging and caregiver issues. In 2011, Jane spent time in the United Kingdom participating in training and peer discussions concerning dementia care. From this trip, she developed a very unique perspective on understanding a person with dementia. In addition to balancing her role as a nonprofit executive, wife, mother, and new grandmother, Jane is also a caregiver for her own mother. As a result, she has personally experienced all the challenges, obstacles, tears, and frustrations that so many are facing. In 2013, Jane was honored with the Rockefeller Award by the Alzheimer Association for her outstanding dedication to the cause and was named Public Citizen of the Year by the West Virginia National Association for Social Workers. In March of 2014, Jane received her certification as a certified dementia practitioner from the National Council of Certified Dementia Practitioners. She is a member of the West Virginia Geriatric Society and co-chair of the Advisory Council of the West Virginia Partnership for Elderly Care. And before I turn this over to Jane, I do want to let everybody know that the handouts for today are posted on HHQI's website. And for Q&As, we have a section ready in the presentation. If you will just put those questions either in the chat box or the Q&A box. So with that, I'm going to turn it over to Jane.
Thank you so much. Thanks for having me. All right, let's talk a little bit about this new way of understanding dementia and what this whole sandwich thing is about. You know, in the 1980s, a social worker, Dorothy Miller, coined the phrase, and I know you have all heard, called the sandwich generation. And it was kind of to describe that generation of folks that maybe had waited a little bit longer to have their kids, and so now they found themselves sandwiched between caring for older parents, but they may still have kids at home, they may have kids in college, and that was her take on this issue. Well, one of the reasons that it's going to be important for you in the home care field to do what you do and learn more about Alzheimer's is this whole sandwich issue. In my 12.5 years in working with caregivers, I realized that it really isn't about a generation. The caregiver might be the 19-year-old granddaughter or it can be the 84-year-old spouse caring for his wife. The point is that when you are a caregiver for someone with Alzheimer's or related dementia, you are literally sandwiched between their world, their needs, their ups and downs, their lives, and that of your own. So I have broadened that phrase a little bit, and that's where we get the whole sandwich thing. But let's talk more about why it's going to be important for those in the home care field to understand Alzheimer's disease or the related dementias. Right now we've got 5 million people with it. That's one reason. They tell us that statistically 1 in 9 older Americans, those aged 65 and over, currently have Alzheimer's. 1/3 of people age 85 and older currently have Alzheimer's, and those numbers are projected to double by 2050. That pretty much means there are going to be a whole lot of people out there who are going to need care, who are going to have this particular condition. Most people, nearly 79%, who need long-term care actually live at home or in community settings, and it's a complicated disease. There's nothing easy and simple about it. It involves the mind and behavior changes, which lead it to be even more complicated. Sleep cycles may totally and completely change. I've been in a email conference with a family now, and that's part of their problem. A person's sleep cycle has completely changed. This person is eventually going to need 24-hour care, whether it's in the home or in a long-term care facility. They will need 24-hour care. And unfortunately, or fortunately, depending on how you look at it, it can last a very long time. There are people living 18 to 20 years with Alzheimer's disease. And I believe that proper training is absolutely crucial to the well-being of the person with the disease, but it's also crucial to the person providing care. So often I hear from families who will say, we can afford to hire care, but we can't find anyone who clearly understands how to interact with mom or dad. So I hope that we can help that issue just a little bit today. I always like to start with this because I continue to get comments about the fact that, well, you know, mom just has dementia. It's not Alzheimer's. As though that's a good thing, and it isn't necessarily. I like to say that dementia is the umbrella term for any condition that can cause loss of intellectual functions such as thinking, remembering, and reasoning. And it interferes with the individual's ability to carry out their normal functions daily. They can't do self-care anymore. And it's caused by physical changes in the brain. It literally is an actual disease. But there are many, many forms of dementia. Now, Alzheimer's happens to be the most common form of dementia, but there are others, and I want to go over these just briefly, and then we'll hone in on the generalities. Vascular dementia, we know vascular dementia. That's the dementia caused by strokes. Now, often with vascular dementia, you're going to see impaired judgment a little more than you're going to see memory loss. There's alcohol-induced dementia that's experienced by people who've been alcoholics for many years. Lewy body dementia causes sleep disturbances and hallucinations and gait issues before you will see memory loss. Pick's disease, or what is commonly known now as frontotemporal dementia, you will see changes in personality first before you'll see the memory loss. Creutzfeldt-Jakob disease is very rare. It's very rapid. You'll see major coordination problems early on in the disease. Then there's the Parkinson's-related dementia that some people with Parkinson's will have, and of course they also experience the rigidity and tremors. In fact, some neurologists believe there's actually a form of Alzheimer's disease that they call akinetic Alzheimer's that will mimic Parkinson's. Then there's Huntington's disease, which can cause a dementia, and then some people at the end stages of HIV/AIDS will develop a dementia. But in general, here's the thing, and I didn't do a slide about this, I probably should have. I call it a duck. Because for most of you, if you're going in the home, or even for family caregivers, if it looks like a duck, it walks like a duck, it quacks like a duck, let's just call it a duck and keep it kind of simple, and you'll see what I mean by that later on in the presentation. People ask me if it's a new disease, and no, it is not. It's just that we've started to figure out what we're seeing. Alzheimer's was actually first documented in 1906 by a German psychiatrist, Dr. Alois Alzheimer. And he documented the condition in a 50-year-old woman named Auguste Dieter. He worked in a psychiatric hospital, and Auguste was in the hospital, and she didn't quite fit the mold of the other patients, so he followed her very closely. He journaled about her. She didn't live very long at all, and he did a brain autopsy upon her death, and he's the first person to talk about what we now know are the hallmarks of Alzheimer's disease, the plaques and tangles. It was in the early 1980s, maybe late 1970s, that physicians finally recognized that what they were seeing, and we'd been calling other things, we may have said it was senility, or we may have said that it was just grandma's kind of crazy, that it was this condition that Dr. Alzheimer had talked about. So it's not a new disease, we just named it recently. It always starts in the hippocampus of the brain. You'll see on your screen, we have a little one right there, and we actually have two of them on either sides of our temple. That's where it always starts, and that's where our short-term memory is housed. That's why that's one of the first symptoms you'll see of Alzheimer's. Yes, it gets worse, it is progressive, and yes, it is fatal. Many times families will ask me, what do you mean it's fatal? And what I mean is that Alzheimer's slowly moves throughout the brain, as we'll see in these slides, and it will slowly shut down all the systems that the brain controls. And of course, the brain controls all systems. So if there is no other acute condition, there's no cancer, there's no stroke, there's no heart attack, in the end, while we may see kidney function failure or heart failure or pneumonia, it will be the Alzheimer's that will cause ultimate death. These are the plaques that Dr. Alzheimer saw. These are normal brain cells. And we have a couple of proteins that we're supposed to have. We also have some enzymes that we're supposed to have. But for the unknown reason right now, that's why research is so important, we don't know why, they start to gather in large quantities in the brain, and one of these enzymes starts to act up like a bad guy, and he starts to slice these proteins. And when he slices them, you can actually see they sort of become curly and sticky, and they start to form plaques. That's called beta amyloid protein. There's also another protein called tau that does the same thing inside the cells. So you can see as this gunk builds up, it slowly causes the nerve connections to break apart and then eventually cell death. It will actually cause the brain to shrink. I like to say it just sucks the life right out of a normal brain. And it does move throughout the brain. The other issue that you're going to start seeing in home care world is we don't have the same old Alzheimer's. One of my friends says, it ain't your grandma's Alzheimer's anymore, because now we're seeing more and more of what's called younger onset Alzheimer's. This occurs in a person under age 65. I have met people who are in their 30s who now have what we call younger onset Alzheimer's. So it is going to affect your business, and the patients or the clients that you see are not all going to be 85 years old, unfortunately. Now let's talk about these symptoms, or what also can be called the warning signs of Alzheimer's. These are the hallmark behaviors and issues that you will see in people with Alzheimer's. They do have short-term memory loss. It's the short-term memory loss that disrupts daily living. And I'm the first to admit that when we can't find our keys and can't remember where we left them, that certainly can disrupt your life that day. But that's not the kind of memory loss I'm talking about. I'm talking about the kind of memory loss where you cannot remember a conversation that you may have had 10 minutes ago. You won't remember what the first slide was in this presentation. You won't remember whether you had lunch or not, those kinds of short-term memory loss. You will have changes in your ability to plan or solve problems. Sometimes one of the first problems you will see is someone who has always been able to balance their checkbook can no longer do that. This was actually the first hint that my mother had a real problem. I noticed changes in her, but didn't want to presume that she was developing Alzheimer's just because I work in the field. And eventually, and she was one of those people who would work on her checkbook when her bank statement came and find that last penny. You know, they can't use that with me to diagnose me because that's what I think a bank's for. I ask them how much I have and they tell me, so they won't be able to do this. But it's also the changes in planning ability, even ability to sequence. This is why people often will say, well, Mom has forgotten how to cook. It's not that Mom literally forgot how to cook, but she'll forget how to sequence. She can't quite remember what goes in first. Does the flour go in first, and then the sugar, and then the milk, and then you have to turn the oven on? It's these changes in planning or solving problems. They'll have difficulty completing familiar tasks. The woman that I met who was 36 when I met her and had Alzheimer's disease said the first time she really knew she had a problem was she couldn't use email anymore, and email was a large part of her daily work, and she simply could not fathom how email would work. A woman I know was always a crocheter, and again, she had younger onset Alzheimer's disease and always had a crochet project going, and she knew that she needed to go see a physician when she picked up her crochet needles one evening and could not, for the life of her, remember what she was supposed to do, couldn't make sense of her directions for the project she was working on. So they will have difficulty being able to do things that they've always been able to do, and that will eventually mean they can't change the channel on the TV, or they can't figure out exactly how to use the telephone. They will have confusion to time or place. This also can relate to that issue with sleep cycles, because they won't realize whether it's day or night. And sometimes a person with Alzheimer's will completely stop sleeping, or they'll sleep, you know, like that young baby, like my daughter when she was born, that would only nap for about 30 minutes and then she was up. She did not take those long naps. This will actually happen to the person with Alzheimer's disease. So I kind of have a different philosophy on this whole sundowning issue, which we can do a whole other webinar on, and that it may not be sundowning, it's simply that their sleep cycles are confused. But they will also have confusion to place. This is the symptom of Alzheimer's that can be the most dangerous. They will become lost in a familiar place. It's quite comical sometimes, or just aggravating, when they cannot remember which room is their bedroom or which room is the bathroom. It is not so comical and most unfortunate when they are out and about, when they've left their yard, when they've gone out into the neighborhood. This is the problem with the driving issue. But also, their reflexes change, but also it may be that for a while they can still drive, but they will get lost. So this is the one that can be most dangerous. And you always need to be aware that any time a person with Alzheimer's or related dementia might wander. Doesn't matter that they've never offered to leave the home. Doesn't matter that they've never offered to go outside of the fence. They may at some point. So it's always good to take precautions and to tell your families that they need to take precautions. The person with Alzheimer's will have trouble with visual images and spatial relationships. Depth perception pretty much goes away. That's one of the reasons you actually see that shuffling gait. It's because they don't know where their feet really are. They can't gauge that, so they will shuffle. And any kind of change in flooring, whether they're moving from carpet to hardwood to the tile floor or back, can cause them problems. A shiny floor, you know, that bright, shiny linoleum floor that we all want, is actually not good for a person with Alzheimer's to try to navigate. Also, the nice black and white or green and white tiles that we might have in our kitchen or bathroom can cause problems, and certainly steps will cause problems. Their vision will also yellow, if you will. They will need a lot more light to see, and they lose their peripheral vision. So when you want to communicate with a person with Alzheimer's, you don't want to stand to the side. You always want to stand in front of them and try to make eye contact, because they will lose their peripheral vision. Their vision will also move downward. Again, you see the shuffling gait and you see them looking down. They are looking down because their vision simply changes and they are prone to look down. So things that you want them to notice, you want to put lower. If we go back to this wandering issue, if you put a lock, just a chain lock, up high on the door, they often will not even, it won't occur to them to look up high on the door, and that's a technique that you can use. They will have problems with words or speaking. Now, certainly we all do that, and when we're standing up in front of a group or when we're doing a webinar, we're afraid that we will lose our train of thought or lose a word. But the person with Alzheimer's or dementia will lose words while they're speaking, and they will be very common words. You or I would probably not forget or lose that word for that thing that we put in our mouth, that thing that we rub across our teeth. You and I would not lose the word toothbrush, but a person with Alzheimer's will do that. That's one of the challenges when you're trying to communicate with them. They lose words or they will substitute words, and sometimes the substitutes don't quite make sense. They will misplace things, and we all do that, but sometimes we can go back and remember which purse we were carrying yesterday to try to find those keys, or what jacket we had on so we could look in the pockets. But the person with the dementia will lose the ability to retrace steps. And what you will see when you go in the home and work with these individuals is the general attitude is it could not possibly be them. They didn't lose it. Someone took it. And if someone took it and you're coming in the home, it just might be you that took it. So one of the things you need to be aware of is that losing the ability to retrace steps, misplacing things, and then they usually try to find somebody to blame it on. They will have decreased or poor judgment, and these will be things like, the grandmother goes out to check the mail in the mailbox and all she has on is her thin nightgown and it's January and 20 degrees outside. All too often we hear about the decreased judgment where they went ahead and agreed to put a new roof on the house when they just put a roof on the house last year. They may pay the same bill over a couple of times, or they may not pay their bills at all. These are things that the families need to be aware of. And again, it can be a safety issue as well. I actually know one woman who spends all her time ordering things on QVC until her kids kind of became aware of that and stopped that. They will withdraw from work or social activities. And, this is often one that's difficult to pinpoint because if the person has had some sort of an illness, has been in the hospital for some other illness, or they've had a spouse pass away, it might seem logical that they would withdraw, but this can also be a symptom of dementia. And then, of course, the changes in mood or personality. And I'm not talking about logical changes in mood and personality, like, mom passed away, so obviously dad is a little bit depressed and more quiet. These will be moment-by-moment changes in mood and personality. The person can literally be laughing one minute, crying the next, and very angry the next. They will also, what we call catastrophic reactions. They will overreact to something very small. They may not be able to find something, or they may be frustrated, and so they will cry or go into a rage where, the non-dementia person would not react nearly as catastrophically. So these are the kinds of things you're dealing with, and there are some medications that are prescribed for Alzheimer's or related dementia. And many of these you may have heard of. Aricept, Exelon, and Razidine are all similar. They all act similarly in the brain. Then there's Namenda, which acts a little bit differently in the brain. So often somebody will be on a combination of the two. Now, these medications don't stop the disease. What they may do is plateau the symptoms for a while. I think that it's good to have the person with the dementia on one or the combination of these medications, so you might keep that in mind as you go into the home. It's also very important that these medications are given at the same time. Exelon is now available in a patch, which is nice for that person who doesn't like to take pills or is very resistant to taking pills. It can also sometimes give people a rash, but all three of these work about the same. But the very best medication in dealing with a person with Alzheimer's or a related dementia to give them a good quality of life is actually going to be you, that person who interacts with them on a regular basis, who goes into the home and is there for them. That's going to be the absolute best medication. And let's talk about this. I mentioned that the challenge of Alzheimer's is the fact that it involves the mind and behavior. I want you to look at these definitions of behavior because it's very important to remember. This is that behavior is usually in relation to the environment, actions or reactions of an object or organism. Behavior can be conscious or subconscious, overt or covert, voluntary or involuntary. Please remember that, because it's not always that they're doing it on purpose. And then, human behavior can be common or it can be unusual, it can be acceptable or unacceptable, but who's to say? Who makes that judgment? Let's talk about this a little more. Also, very important for you who go into the home, if it's a sudden change in behavior, it's not dementia. All too often we blame everything on the dementia. But if the person was reasonably and just pleasantly confused yesterday and today they're absolutely on another planet, something is going on. Many of you may have heard this before. 9 times out of 10 is going to be urinary tract infection. For a variety of reasons, people with the dementia get urinary tract infections very easily, and the slightest infection can send them off into another realm. Dementia most of the time progresses slowly, So if you see a sudden change, look for something else. There's some other acute issue going on, or it is in response to the environment in some way. People with dementia absolutely do communicate, but they may communicate in different ways than they have before, and part of your job is going to have to be to figure out what they're trying to communicate with you. It's not the person, it's the disease, and unfortunately right now we can't change it. But what we can change is how we read or interpret, and most importantly, how we respond. A good friend of mine met me in the grocery store, and I asked how her mom was, and she said she's absolutely driving me crazy because she keeps talking about the house next door that we used to live in. We never lived in that house, and I tell her that over and over and over. I could tell that my friend was extremely frustrated. Many of you might have heard this before. She keeps asking for her husband, and you know that he died 5 years ago. You figured out that you probably shouldn't tell her every time she asks that he died because, of course, that upsets her. But if you tell her that he'll be here later, she's still going to ask for him every 15 minutes. What are you going to do? Is there anything you can do about that? The person who wants to go home, he wants to go home, he wants to go home, and he's actually sitting in the home that he's lived in for the past 30 years. What kind of answer can you give him so that he won't ask again and again? I got this when I worked at the Alzheimer's Association. We have an 800 helpline, and a daughter called, and I was speaking with her, and the daughter lived out of town, and the daughter told me that mom had been diagnosed with Alzheimer's, but it was very important that mother remember to take her insulin because she's diabetic. That one was interesting. So how are we going to communicate with these people? What do we do? This is an interesting story that I'll use later. This, again, was an actual call. I received a call from the daughter who had her dad in the car, and they were driving around. Dad, unlike many older gentlemen, especially here in West Virginia, where we sit, did not collect guns, but he did collect swords. And that morning, and it happened to be February, he was out on the front porch of the house. They'd come to live with their daughter, and he was out in the front yard, actually, with his sword, just swinging it around. And his wife, being the typical wife, like many of us, went out and said, you need to get in here with that sword. You're going to get cold. You're going to get sick. The neighbors are going to think you're crazy. Get in here with that sword. And, of course, like a good husband, he didn't pay any attention to her. And after a bit of a conversation and the voices got louder, the wife went down into the yard and grabbed his arm and told him to give her that sword, and you might guess what happened. The good news was, by this time, the daughter had heard the yelling and the shouting and had gone out. Dad did not harm Mom, but the daughter was able to distract him and get him in the car with his sword, and she was driving around and called me wanting to know what to do. So how are we going to communicate with these people who may be what in this case seem to be quite aggressive? We hear about this a lot. And this is my good pal, Dr. Phil, who says, so how's that working for you? Well, as Andrea said, I was privileged to go a couple of years ago to study with a woman in England. She has built upon this philosophy of person-centered care that has been the hallmark of dementia care for the past few years, and she's developed her own philosophy about it, and she really moves deeper, if you will. This is the guy who invented this whole philosophy of person-centered care, Tom Kitwood, and many of you probably heard of him. Well, Penny Garner, my friend, says that what we really want is lifelong well-being for the person with dementia. That's the key to it all. And if that person with dementia has lifelong well-being, then certainly those who care for them are going to be less stressed and have lifelong well-being too. So how do we manage this dementia? Well, Penny says here's one of the things that we have to understand. Her view is that a person with Alzheimer's or related dementia is pretty much just like the rest of us, except they've lost some photographs in their album. When I first read the book that Penny's son-in-law had written about this philosophy, I read that and I literally, popped my hand on my forehead and went duh, because it made such good sense to me. Let's think about it a little bit. If I ask all of you out there to close your eyes real quick, don't fall asleep because you're on a webinar. But if I ask you to close your eyes and think about your first grade experience, I guarantee you're going to see pictures in your head. You're going to be able to see that school or that classroom. You might see a school bus. You might see your teacher's space. You might see exactly where you sat in that classroom. That's a visual picture in your mind. Oh, there you go. And if you didn't like your teacher, if she was a bit of a gruff lady, then you're not going to have a very good feeling about your first grade experience. And so all of our memories, if you think about it, really are just like pictures on our mind. Weddings, vacations, the new baby, you can see all that in your mind. If I ask you to close your eyes and think about your first pet, I was doing this workshop in front of a group of people, and one guy about a year ago actually said that his first pet was a groundhog. So afterwards, I wanted to ask him more about that. But I guarantee you, you can see that dog or that bird or that kitten or that groundhog that was your first pet. And those pictures in your mind, just like that teacher that you didn't like, give you feelings. And for the sake of simplicity, we're going to talk about the fact that good feelings are green feelings and not so good feelings are red feelings. So if you remember your first pet fondly, but that puppy was hit by an automobile when you were a kid, you might have some mixed feelings, or seeing a puppy sometimes might give you some red feelings or not so good feelings. So remember, these people who are going back in time in their minds might be losing some pictures in their album, but some of their album pictures also might give them some unfortunate feelings because they can't sort through them. You can also have a feeling without the picture. For instance, if your boss at work this morning when you walked in said, "You have done such a fabulous job. Not only are we going to give you a raise, we're going to give you a bonus as well." Maybe every minute of the rest of the day you won't think about that, but you're going to hold that good feeling. Now, by the same token, if you walked in today and the boss said, "Okay, what you did was really bad. You really messed up. We're going to have talk about this," you may walk around with a knot in the pit of your stomach for the rest of the day. You might not remember the exact circumstance, but you're going to remember the feeling. And people with a dementia do the same thing. So let's talk about these 5 golden rules. There are 3 golden rules, but my friend Penny says maybe there are 5. And if you're going in to work with a person with a dementia and you want to get along with them and you want to communicate well, here are some keys. First, stop asking the question. And that's one of the first things we do. How are you today? Do you remember me? And here's what happens. Every time you do that and that person can't answer the question, it's like you stick a knife. It's like you're rubbing salt in the wound. You're saying, look what you can't do. And we all do this. It's a very natural thing to do. I would often stop by the assisted living where my mother lives after work in the evening. And, you know, there weren't a lot of things to talk about. Sometimes she would ask me about my day, and I would try to explain it to her. And unfortunately, I did the wrong thing. I would say things like, well, how was lunch today? And one day she literally looked at me and said, stop asking me that because I can't remember and it makes me mad. Because think about this. If you ask Mr. Smith if he would like a cup of tea, poor Mr. Smith has to process in his mind first, do I like tea? I don't even know if I like tea. Now, she said cup of tea, so I guess she means hot tea versus iced tea, but maybe she meant iced tea. Maybe I didn't hear her well. Oh, no, wait. Yeah, she said cup, so that means hot tea. Do I like hot tea? And if I like hot tea, do I like anything in it? I don't know. And then if I drink it, am I going to have to pee? And then I got to find the bathroom. So you really put a lot of pressure on Mr. Smith when you ask him. The other issue with people with Alzheimer's is a lot of times they can process what you say, but it may take them up to 90 seconds. I guarantee you if I pause on this webinar for 3 or 4 seconds, you're going to wonder if you've lost your connection. You're going to wonder if I've fallen asleep. But to think it might take me 90 seconds to come back and give you a response, that's a long time. So by asking them these questions, then you create confusion in their mind. You point out that they have a problem, and then you're probably going to move on in about 10 seconds if they don't answer you, and you'll either give him the tea or presume he doesn't want any. So if you can avoid asking questions, please do so. Now, you can make a suggestion. You can say, you know, I think a cup of tea would feel great right now. How about you? So you've given them some clues. It's much easier for them to say sure or okay. No is also a very easy answer. But if they don't have to stop and think about it, and you've already given them the hint that this would feel really good for you, then they may answer you. Also, never contradict. I hope during the question and answer period that the person who has won the argument with the person with Alzheimer's and related dementia will let us know that. Because I guarantee you, you never win the argument. You're never going to win the argument, so it's best never to contradict. If you can agree with them or simply keep silent, that's going to work better for you. You also need to let them be the expert. And by that, I mean they're going to tell you, maybe in a different way, they're going to tell you what they need. Again, if there's a sudden change, they're telling you that I've got something acutely wrong with me. It's not my Alzheimer's. They will tell you when they need more care. Families will say to me, you know, Mom loved to go out to eat, but the last couple of times we took her, she becomes very agitated. She won't sit at the table. She wants to get up and leave. What's the problem? Well, Mom is probably telling you that she's not able to handle that stimulation anymore, that she can't go out to eat anymore. They really will be the expert if you will let them. The other thing you need to do is if they start to talk to you, if they start to tell you something, you need to be quiet. First of all, if they finally gathered their thoughts and they have something to say to you, the slightest interruption will take them off course. And the most important thing that you can remember in all this, it's all about their feelings. It's not about the facts anymore. So you need to find the correct answers, answers that can provide longer satisfaction, that can give them a green feeling, that allow them to make sense of their present, and that give them a good reason to be dependent. Because sometimes you need them to sit down and take their medicine. Penny talked about a woman that she worked with who had had back issues all her life, and she actually remembered that she had a bad back. So whenever this woman would get agitated, they could say to her, now, Ethel, you don't want to throw out your back, do you? Because you know what that's going to be like. And she would calm down. Another gentleman that Penny worked with had actually been a mover, literally a furniture mover. And when he would become very agitated, one of the things they could say to him, because they were in England, was, George, it's time for a cup of tea. And no matter the time of day, it didn't matter if it was 8 o'clock in the morning, if they said that, he would calm down, he would sit down, they would serve him a cup of tea because he expected it, but it would calm him for at least an hour to an hour and a half. It gave him a reason to be quiet. Kind of like watching a movie with subtitles. You know, if you watch those foreign films, you can sometimes kind of figure out what's going on, but there's some subtleties that you just can't figure out unless you have those subtitles. So one of the things you're going to have to do is figure out those subtitles. So we never lived in that house. My friend was not winning that argument with her mother. In her mother's mind, they had lived in that house. So rather than it driving my friend crazy, if she could focus on the feeling, not the fact, she might want to engage with Mom and say things like, that sure was a great house, wasn't it? And then you never know what conversations you might get with Mom, but it certainly would not create the stress for my friend or for the caregiver. And it doesn't really matter, because if that photograph album of my friend's mother had that they lived in that house, then that's her photograph album. Think about it. It's your album. You know what's in it. No one else can tell you what's in your album. I want my husband. One of the things that my friend Penny talked about in England was a woman that she worked with who consistently asked for her husband, and no matter what they told her, he's gone to the doctor, he's gone to the store, he'll be back in a few minutes. She would ask every little bit. So I tried to find an answer that might satisfy her longer. And what Penny discovered after asking lots of questions was the woman's husband used to own a sailboat, and he would go sailing. And she didn't mind. It didn't bother her. She didn't like sailing. She didn't like to get her hair messed up. She got seasick. So when he would take his boat and go sailing for the afternoon, that was her chance to go out to lunch with her lady friends and go shopping. So they finally learned when she asked for her husband to say, he's gone sailing. And you know, she didn't ask again for hours. They found the right answer. Now I want to explain a little bit this want to go home, because often it's the emotion. Again, I said focus on the feeling, not the fact. Often when someone says they want to go home, what they really mean is, I want to feel safe and secure. Now, they might have moved back in time in their mind, and they might be thinking about that home that they lived in when they were 5 years old. But often what they really want is to simply feel safe and secure. So one of the things you can do is say, tell me about your home. Did you live on a farm? What was your home like? And you can distract them, but more importantly, look for what might be making them feel threatened or insecure, and that might solve the problem. So let's talk about your peaceful dementia mantras when you go into the home and you're going to work with these individuals. Feelings are more important than facts, as we've just stated. If they're upset, deal with the upset. If they're not upset, then you probably don't need to be upset. You need to remember that any good feeling is better than any bad feeling. This is why you don't necessarily want to contradict. You don't want to say, no, that's not right. That's not what happened. Because we want a good feeling, not a bad feeling. They already feel bad enough. They know they're losing control. They know they're losing capabilities. We don't need them to feel worse. The person with dementia will lead your way. I want to tell you a quick story, only because it's too good not to. I got a phone call early one morning from a woman who had what we call here in West Virginia legally unlicensed personal care homes. It was a little care home where she could keep 3 to 4 people in her home. And she said that there was a lady there with Alzheimer's who had continually been digging at her rectum area. And they wanted to know if there was a medication that they could talk to the doctor about and getting this person to stop doing this. Well, I started asking lots of questions, and it turned out as the questions increased that I discovered that this woman had irritable bowel syndrome. That's not what the caregiver was calling it, but that's what she had. She was wearing Depends. She would have days of constipation, then she would have fits of diarrhea, and it just finally occurred to me and asked that they have this woman checked for hemorrhoids. And it did turn out that this woman was suffering from hemorrhoids. Well, now, I hope this is not too much information for you all, but out there, if any of you have ever had hemorrhoids, I guarantee you there were moments when what you wanted to do was really dig because the itching and burning was just unbearable. What this person was trying to say was, please go to the drugstore, get me some Preparation H because I'm miserable. But she couldn't say it that way. But she was the expert. She was trying to tell everyone where her problem was. Now, this next one, sometimes with family caregivers that makes them feel terribly guilty, and I don't mean to do that, but it's actually the caregiver that holds the keys to the peace. Because if you can go along, if you can agree, if you can enter their world, it's actually going to be a lot more peaceful than if you continually try to correct and remind and help them to feel, to realize the logic in something. It's simply not going to happen. The other thing you need to do is listen to the person with dementia, because sometimes in their confusion and their substitution of words, they really can give you a message if you will just stop long enough to listen. It's very important when you're having sort of that tug of war that you might count to 3 and say, you know what, you were right, even if they're actually factually wrong. Let them be right. No questions if you can possibly avoid them. Also remember, the last in is the first out of the photo album. That's why it's very important, if you're the person going into the home, that you introduce yourself every single time. They will remember something that happened to them when they were 5 years old, but they may not remember that you were there yesterday. So it's very important that every time you come into their home, you introduce yourself to them. You want to approach from the front and speak slowly. Remember, it takes them longer to process. They might be able to process, but speak slowly. You're going to have to learn to love repetition because they will tell you the same story over and over and over, but that's okay. It's what's left in their photo album, so let them enjoy it. You want to say silly me, not silly you. You know, maybe it was you that forgot to shut the cabinet door, not them. Maybe it was you that left the water on, not them. Because, as I said before, they're already losing control. They already feel technically bad about their losses. We don't need to point them out. Again, sometimes there's no right or wrong. It's just what works best for that person with dementia. If you find the right answer, if you find the right technique that calms them, that makes them happy, then that's the best. You also need to validate before you ever orient or distract them. Remember when I said maybe you can say to that person, tell me what your home was like, to distract them? That will never work unless you acknowledge their feeling. If they're upset, you need to say, you seem very upset, or you seem very angry, or you seem very afraid. I know it must be hard for you to have a stranger come into your home. I can't imagine how that must be, and I'm so sorry. After you've said that, after you've acknowledged the feeling, then you can distract them. But if you don't acknowledge that feeling, it's not going to happen. A gesture can be worth 1,000 words. They really pick up on nonverbals, so remember that. And also just learn to make a present of their past, because that's all they have left. I want to tell you one last story. One of the first things that Penny dealt with her own mother was the fact that her mother decided early on in the course of her disease that whenever they were in a public place, must be an airport. The first time this happened, they were actually in the grocery store doing grocery shopping, and her mother started talking about where are we going and what gate do we need to go to and what time does our flight leave. And, of course, Penny was already a frustrated caregiver, and she was very upset with her mother and said, what are you talking about? We're in the grocery store. But this kept happening. They would be in church. They would be in a doctor's office. And finally, one day, they were actually at a medical clinic waiting on a blood test, and her mom mentioned something about the airport. And Penny was just so tired and so frustrated that she just went with it. She goes, yeah, we're flying to Disney World. And they ended up having the most delightful conversation. Now, Penny said everyone sitting around them in the waiting room thought that there must be two nutty ladies sitting there because they could hear their conversation. But they ended up having a delightful conversation. And that was the first time that Penny actually relaxed as a caregiver and enjoyed, I guess you could almost say enjoyed her mother's dementia. Now, she said that over time, she got pretty bored with the airport travel stories because often they would be the same stories, but she learned to just go with the flow with her mother and enter into her mother's world for the most part, and it made for much better communication, much less stress, and actually some enjoyment. So what I'm going to say is, let's try to have lifelong well-being for the person with dementia. I think if you work in home care, it's very important that you understand the mindset of the person with dementia, that you understand the impact of all that they're experiencing and going through, and you kind of do enter their world as best you can. I guarantee your job in working with them and taking good care of them is going to be much easier. So I'd like you all to have a nice flight as we're all sitting here in the airport, and I'll be happy to answer any questions anyone has.
Oh, thank you so much, Jane. That was an excellent, excellent presentation. So I'm going to put a reminder out before we start to questions, comments, anything that you'd like to put, you can put that into the chat box or the Q&A box, and we'll entertain Q&As. But there was just so much great information, and boy, does it really put, from a healthcare perspective, really puts you in a different mindset of understanding, especially communication, and some of the tips and tricks are things that aren't taught in books and will make life such more enjoyable for the patient caregiver as well as for healthcare workers. So everybody go ahead and start putting in some questions or comments into the chat and the Q&A. Whoops. And while we're waiting for that, I'm going to just throw out something. This was actually from an early part of your presentation, Jane. You talked about Alzheimer's and dementia occurring earlier and earlier and we're seeing that in people. I actually want to recommend, it's just a novel, but if you want to really kind of get a mindset of what it would be like to be, especially a younger professional, having this happen, my sister-in-law had recommended a book to me, and it was called Still Alice. And it's just a novel, but it's based upon interviews of patients, family members, physicians, and the premise of the book is a college professor at a well-known college has the Alzheimer's disease, and the subtle signs, and then the realization of how it was affecting her personal and her professional life, and that struggle of finding when she had to let people know. And it was a book that I read within 24 hours. It was a great read, gave me a different perspective, and that's called Still Alice. And it's by Lisa Genova, if anyone's interested for another perspective.
Yeah, that's a great book. I've actually met Lisa, and I'm told that they're working on the movie as we speak.
Oh, really? Good.
Yeah, there's a movie deal. And I also should mention the book that I spoke about that I had read that kind of led me to this new philosophy. That book is called Contented Dementia, and it's by a gentleman named Oliver James. It's actually my friend Penny Garner's son-in-law who wrote this book because he was so fascinated with her work and her philosophy.
Could you repeat the name and the author again?
I can. It's called Contented Dementia by Oliver James.
James. James. Okay, great. All right, we do have some questions coming in and comments. Let me jump up here first. And thanks, Marie. Marie also said that was a wonderful book, too, the Still Alice. And I have another message from another comment from Lisa. If someone's in the beginning stages, how do you get buy-in to start medications that might help? Great question, Lisa.
Well, I think that in the beginning, whether they want to accept the fact that they have a specific type of dementia, usually what will work is if you can say, this is something that may help your memory. Because the reality is sometimes these medications can, to some extent, restore some ability. I'll never forget the first time I met a gentleman who had just started on Namenda. We were at a national conference, and he had lost his ability to tell time. And after he started on Namenda, which is often started in the middle stages of a dementia, he had regained his ability to tell time, and he was so excited. And during that whole conference, he would just walk up to you and say, you know, it's 10 after 3. And then a little bit later, he'd say, it's now 20 after 3, with a big grin on his face. Sometimes you have to be a little creative, and you might have to talk to them about, you know, I've had people call them vitamins. But if the person is aware that they have a dementia and will be cooperative, then saying that sometimes these medications will help their memory, it will usually work. Now, if they're really, really resistant, then, you know, that's why some people use the patch. You know, you can literally go up to Dad and pat him on the back and say, how are you doing, Dad, and plop that patch on there, and that's actually where you usually put it, is on their back where they can't reach it. But if they're aware of the illness and you can convince them that they can be proactive about it, usually you can talk them into it.
Great, great.
I want to comment on that, though, because that's why it's also important for us to urge people to get an early diagnosis, because the earlier in the course of the disease, the more amenable they're going to be, the more cooperative they're going to be. All too often what we see is that the time they're diagnosed, they're actually no longer in the true early stage, and so sometimes they will become resistant and say, well, I'm not going to take those pills, you know, and they become a little bit resistant.
Great. And we have a question from Bridget. What is safe to discuss with a client that related to painful or sad memories? So what is
as much as they want to discuss. You kind of have to let them lead you. You don't want to consistently bring something up to them. For instance, let's just say they're asking for their mother, and they ask for their mother over and over, and when you explain to them that their mother passed away, they become very upset. You don't want to continually do that. After you've addressed the issue with them a couple of times and it's very clear to you that they're not going to remember that, then you have to come up with a better story, kind of like, you know, he's gone sailing. Because sometimes this will happen, or let's say they've lost a child, and they become wrapped up in that memory of losing the child. You want to try to distract them from that, talk about the good things about the child, but often you'll see this, and this can often be a behavior that's upsetting. You know, let's just say maybe you're the home care worker and you remind them of someone that they have a bad memory about. You know, it may be that you're just going to have to switch off with a coworker because you're never going to be able to combat that. Or they see a young child and they become very agitated and very upset. Well, it might be that maybe they lost a child years ago and it's that memory that's disturbing them. But you want to let them be the lead. Let them talk about it as much as they need to. If they don't need to talk about it, then you don't need to talk about it. Does that make sense?
It does, very much so. We have another question here from Arlene. let's see, is it important to go through all the various testing to diagnose dementia, or is it just appropriate to treat the symptoms of dementia without knowing the specific type?
It's sometimes very difficult to figure out the specific type. You can go through a wide variety of tests, but unless you're seeing some extraordinary behavior, like sometimes people with the Pick's disease, frontotemporal dementia, will become very angry and have major hallucinations. You need to know that that's what you're dealing with, that it's Lewy bodies, that it's Pick's or frontotemporal. So in some cases it's important, but again, if it's just, I know this is unprofessionally sounding, but if it's just a duck, then you can just treat it as a duck. Does that make sense? I think all too often people go to such great lengths to find out which one it is, and sometimes it doesn't matter.
I think that's an excellent way to describe that. And we have a comment from Emily. She did read the book still, Alice, an excellent book, she said. Also, the author also has another one that's related to traumatic brain injury, so that may be something that is relevant to the scope of practice that you have or the type of populations you care for as well. If there are any additional questions, go ahead and shoot them into the chat in the Q&A. We're going to move on to some additional resources and some update information. If we have time, we'll come back and we will go ahead and hit those questions as we finish. First, some additional resources. We wanted to provide you some hands-on resources that are out there through national organizations. So the National Institute of Health has a variety of excellent resources. There's some caregiving tips for coping with, you can read the slides to tell you, and the slides are posted on the website, and they are hyperlinked to the actual site. So they're all available, and there is the one that is on forgetfulness, knowing when to ask for help, and it is available in both English and Spanish. Next slide, please. Also, the Hartford Institute for Geriatric Nursing provides the mini-cog, which I know a lot of physician practices use as their diagnostic tool. Also, there is a feeding and eating issues in the older adults, Part 1 and Part 2, as well as assessing pain and some home safety inventory. Next slide. Some additional screenings. There is the AD8 dementia screening interview that's available. You have to use the tool as it is written, but it is free and totally available because that is how it's been tested to be proven evidence-based. The Cornell scale for depression in dementia is appropriate, and there also is a complimentary scoring guide and administration that is available, and the 7 stages of Alzheimer's from Alzheimer's Association. Next slide. The Alzheimer's Association has a ton of resources that are great for health professionals as well as families and caregivers. So you can find information there. There's education, there's e-learning, there's all types of information on updates for clinical trials, can we help, tab, and local chapters for in your area. Next slide, please. Before I tell you about the next Upward Network, I will tell you, if you have signed up for, or when you signed up for this session, for the update, which is the newsletter for the underserved population, it will come out in the next 2 weeks. The focus is on Alzheimer's disease, and there is some of those resources as well as a few additional things, including a nice short 2-minute video on some of the statistics that could be used within team meetings or something to introduce the topic. This session is being recorded, and I think there is just such great value that Jane brought today that you may want to pass this on to colleagues. So by Monday, this session will be posted on the Underserved Population tab of HHQI. And if you're interested in the update and don't know if you've signed up for it, do just send us an email, and our address is hhqi@wvmi.org, or you can find that connection anywhere on our website. Now, kind of taking off on the caregivers, our next up network event is going to be June. And if you follow us, we typically are twice a month calls, but for the summer months, we will just be once a month. June the 11th is the Universal Language of Caregiving, what we need to know now. And our keynote speaker is Kim Linder, and she is a fascinating person, just very much like Jane, and very passionate about teaching others, about working with caregivers and empowering them. She is a senior advisor. She is a caregiver coach. She has a radio talk show and is a consultant. You can sign up and register now for that session. We also will have two of our stakeholder work committee members that are going to speak 5 minutes to talk about their personal experiences, because I know many of you on the call, and I'm included, do that dual role, that sandwiching that Jane has talks about, where we are the professional, but we also are caregivers and take care of our family, et cetera. So she'll be addressing they'll be addressing some of that from their experiences. Next slide. Okay, you can connect with us a variety of ways of HHQI, but I do want to kind of mention Facebook. If you don't connect with us yet on Facebook, yesterday Misty Dyke posted a really good video, or an article, sorry. The article is from Little Rock, Arkansas, about a wonderful story about a gentleman and the police officers that found him as he was wandering, and he had a purpose, and I think it's an excellent article you should read, and we have a link to that on our Facebook site. So next slide, and I think we're pretty much to the end of our time. There is an evaluation. I really do recommend that you fill that in, and in this, there is an area that provides some other future topics that you're interested in. We do look at that. Please do put something there that you're interested in. And the slides are posted today on the HHQI website on the Underserved Population tab, and you will find the slides there. And it's also included in the chat site as well. And that's all that concludes. We want to thank you again so much. Jane, you're a remarkable woman with a ton of experience, and we thank you for sharing today with us.
Thank you very much. I appreciate the opportunity.